So, introducing our very first speaker for today. The COVID-19 pandemic has shown us how weaknesses in our health systems can have intense implications for health, economic progress, trust in governments, and social cohesion. Containing and mitigating the spread of disease and infection remains a massive priority. But so is strengthening the capacity of health systems to respond quickly and effectively to healthcare challenges so that our people can have better health outcomes. Dr. Fareed Abdullah is our next speaker, and he will take an in-depth look at the impact of COVID-19 on our healthcare systems. Dr. Abdullah is a specialist in public health medicine and currently a director at the Office of AIDS and TB Research at the South African Medical Research Council. And since April 2020, he has been a member of the Steve Biko Academic Hospital Outbreak Response Team, working as a clinician in the COVID-19 wards and assisting with the provision of COVID-related equipment, staffing, and infrastructure. He was also part of the COVID-19 vaccination team at the Steve Biko Academic Hospital. Ladies and gentlemen, please welcome Dr. Fareed Abdullah.
Well, good morning, everybody, and thank you, Anna and Ahmed, for the invitation, and thank you for having me, Leanne. I'll just go through my slides quickly, a little more technical than everybody else. Apologize for that in advance. But before I do anything, I just want to say how much it's been a real honor and a special privilege working with a whole lot of doctors at Steve Biko Hospital during the COVID pandemic. Young doctors, doctors who've been there for a long time, and who've just thrown their entire lives and careers at the pandemic. It's been a pleasure working with them over these last 2 years, and I think we're just so we can be so proud of the efforts that has been done at the hospital. So I want to cover a few areas here. I'm very aware of the time, Salome, so I'll stick to it, and hopefully just try to reflect on what's happened over the last 2 years and what might be some pathways to kind of go forward here. So starting with the size and shape of COVID, well, I think what's really important is that we know that this has been a major shock to the system of the world. But I just want to point out from this paper in the Lancet a few weeks ago that there's been a serious underestimation of the number of deaths, and we now have well-documented estimates that there are probably between 17 and 19 million people globally who've died from COVID-19. You know, if you want to compare it to something, then there were about 50 million deaths in Spanish flu epidemic between 1918 and 1920. The HIV epidemic has had about 37 million deaths over a period of 4 decades. But, this epidemic has been a major shock to the system. This is a picture in South Africa. This is great data from the Medical Research Council. And you can see those blue lines across the 4 waves and the officially reported deaths. And those are people who died in hospital. It's just approaching 100,000 deaths now, as the president announced in his talk last night. But at the MRC, my colleagues documented what we call excess deaths. And we think that the death toll from COVID-19 over the last 2 years is in the region of about 300,000. So these are hospital admissions as documented by the National Institute of Communicable Diseases. They've done a fantastic job to document the hospital admissions across the public and the private sectors. And you can see that waves 2 and 3 were big waves, and wave 4, the Omicron wave, started to see that decline. So we estimate about 500,000 admissions. But you'll notice that the split between the public and the private sector is rather different from what you would expect, because about 15% of the population is covered with medical insurance. You would have expected a lower rate of admissions in the private sector. So it's an interesting discussion point about why the private sector accounts for almost half of the admissions. And that could be a function of a more forgiving eligibility criteria for admissions into the hospitals, or it could be that the public sector didn't have the number of beds that it needed to take on more people, because you'll figure out from this that about 2/3 of the patients who died never made it into the hospital in this country. Excuse me. So these data are from Afrocentric. Thank you, David de Villiers, for this data. And it shows the picture we've seen across public and private sectors. In the green line are the admissions in the private sector, and then you can see that there's been a significant decline in 2020 and 2021. This is a really important discussion point, because we need to understand what happened there, and basically you can see in certain hospital admission categories, you can't really stop a cesarean section or a normal delivery, so those have kept pace with previous years. The trauma admissions went down, and that's partly due to the lockdown regulations. That was a big discussion over the last 2 years. But there's some things we don't fully understand, such as asthma admissions. Why should it be fewer? But it certainly has been. A great concern has been admissions in cancer patients. Now, this is in the private sector, and it's clearly going to be even worse in the public sector. So patients who had cancer were not coming to the hospital, or because there was a shutdown of many of the kind of non-COVID functions within the public and the private sectors, we see this fall off. And I guess where I'm going is to understand what's going to happen over the next 2 years. Will there be a rebound, or will it continue at this lower new set level? So these are data from colleagues at Right to Care in a public sector district, and you can see a similar picture. These are our clinic visits, and you can see between a 15 to 25% decrease in head counts. So people stopped going to the clinics for multiple reasons. Sometimes the clinics were closed. Sometimes they were afraid to go to the clinic, not to be infected. Sometimes the staff at the clinic were down, so the numbers of patients they saw were fewer. And I don't have the data for this, but we know from all our colleagues in the private sector that GP visits went down significantly. I asked Adrian Gore a question about this about 8-9 months ago, about whether this would be a new level of GP visits set for the private sector, or will there be a recovery. He thought there would be a recovery, but I think that's something to think about. This is the slide that concerns me the most, working with tuberculosis. And what we saw in the first 6 months after COVID struck is a 50% decline in TB testing. And, you test fewer people, you make fewer diagnoses, you treat fewer people. And actually, we've seen in the last 12 months an increase in TB deaths recorded for South Africa. That's the sort of epidemiological effect of COVID on other disease patterns. So basically, I have one overarching message here, and that is that COVID has knocked down inpatient and outpatient care in both the public sector and the private sector, and it's going to be interesting to see over the next 2 years if there's going to be a rebound. It's also really important that we monitor the impact of that on mortality and morbidity. So at the Steve Biko Hospital, we've just put together a study to look at hospital admissions and death rates for inpatients in the 2 years before COVID, uh, during the 2 years of COVID, and what we're really interested in seeing is what would happen over the next 2 years. And our hypothesis is that there'll be an increase in deaths from untreated HIV, untreated tuberculosis, oncology, and a lot of those patients who really needed care and surgery, the quality of their care, their lives will be worse over the next 2 years. And I'll come back to this in the conclusion. So that's the first overarching point. The second, and I'm delving into territory that I'm not really an expert on, which is the financials. So a couple of slides on this. The first is that there was a big investment made by government of around 37 billion rand in the public sector, most of that going to provinces and quite a bit of that going to vaccine procurement. That number came down substantially in 2021. At the time of making these slides, there wasn't an allocation yet for 22-23, but there has been an allocation at a lower level. But this is the investment that government made in direct healthcare. Ahmed, you'll be interested to see this slide. A lot of other people came to the party here. It's not so well documented, but apart from the Solidarity Fund, which I have had a lot to do with over the last 2 years, great group of people making a significant investment, quite a bit of that into healthcare. Don't forget that Solidarity made the first payment for COVAX for our vaccines. So critical strategic investments. But rather lesser known are the big donors to South Africa, the Global Fund, PEPFAR, making significant investments. I know at Steve Biko we got a donation of high-flow devices. We got a donation of 10 LTE 200 ventilators, which we used all the time. I'm not sure about the medical schemes number, but according to Dr. Sipho Kabane, in 2020, medical schemes spent about 24 billion rand. So a lot of money was invested in the COVID health response, the direct health response. But let's just drill down a little bit here, because on the one hand, whilst there has been unplanned, unpredictable expenditure in the medical scheme sector, in the private sector, if you want, there has been some offset by the reduction in admissions. So an interesting offset here. The net effect of which is actually quite a windfall for the medical schemes. The 2021 data are not there. But speaking as a doctor about money, I'd be really interested to know what the private sector is going to do with this windfall, with these surpluses. And not only how they're going to share it with everybody else, that's not where I'm going, but how it's going to impact on trends and what the private sector is going to do with this windfall over time. I'm sure you'll talk a lot about that, and I won't venture any further here. The opposite has happened in the public sector. These are data. I serve on this presidential health committee, Ahmed, Dr. Anna. And actually, we have a completely different set of financials here. Basically, whilst there has been an investment in the health services to pay for COVID, everybody, including the health sector in the public service, had to contribute to that huge 500 billion special adjustment budget that Tito Mboweni announced in and around August of 2020. So health had to contribute to that. And the net effect is that the impact on the provincial budgets is quite substantial. It's a 76 billion rand reduction. I would go as far as saying that the cuts to provincial health departments over this year and the next 2 years is larger than any cuts we've seen since 1994. And that puts the provincial balance sheets under significant pressure. So really, quite an important point. You can see a completely opposite reaction, opposite effect of the impact of COVID on the financials in the private sector versus the public sector. So what really are the implications of that? And these might not materialize because we're looking into the future, but we potentially have a situation here where there are budget cuts to the provincial health departments at the same time that we expect a rebound in utilization. That's got to lead to contradiction. The second point is that COVID's not gone yet. And even in our fourth wave, we still had quite a few deaths. We'll have a fifth wave and a sixth wave, and like everybody else, I'm of the view that the deaths will decrease with each wave, that we have COVID under control. But there will be a fifth and a sixth wave, and there will be a cost in lives and in rands. That puts the public sector under tremendous pressure. Wage negotiations are subjects I shouldn't go near, but the public sector has not budgeted for what might be a higher than expected wage increase. Salaries puts a lot of pressure on the public sector budgets, so that's something to think about. And then governments like the Gauteng Health Department owe a lot of money from previous years, what we call accruals. And between the accruals and the budget cuts, the provincial balance sheets have been significantly weakened by COVID-19. And then, COVID vaccinations are likely to become an annual expenditure. So that's going to put more pressure on the public sector financing. So let me move on a little bit. How am I doing for time? I think I'm still okay. On the left is the place I've spent a lot of my time in the last 2 years. That's the COVID high care ICU ward. It's a makeshift 37-bed ward on the grounds of Tshwane District Hospital, run out of Steve Biko, staffed by Steve Biko. And on the right are those tents that almost every hospital in both the public sector and the private sector put up to screen patients, because this is the essential triage step in the care of hospitalized patients in this country and globally. So instead of going into the emergency unit, the patient is put in a tent or some facility at the emergency unit until they have a COVID test, and the COVID positive patients get put in a COVID ward, and the COVID negative patients get put into whichever ward they would have gone into anyway. This has been the singular, most disruptive kind of change in the basic care of hospital patients. And in a way, we're kind of stuck here because we still have COVID wards and we still have patients under investigation who need to be triaged. But the profile of COVID has changed. This is a study which we did at Steve Biko and published it in December of last year, showing that patients in the hospital here, most of the patients in the COVID wards now have what we call incidental COVID. That means that they are in the hospital not for the classical COVID pneumonia with respiratory distress, but they have a COVID positive test and a gunshot wound, or a COVID positive test and heart failure. But they have to be treated in a COVID ward. And we're kind of stuck now in these COVID wards with the majority of patients who are there with incidental COVID, and we still have to treat them in isolation. And really the next thing to figure out for all of us in both the public sector and the private sector is how to navigate our way to reintegrating COVID care into the normal services. The Ministerial Advisory Committee just last week has put together a team to look at this. But I want to conclude. So that's the first sort of change in the evolution of COVID. The second change in the evolution of COVID is this graph from Gauteng, which basically shows that we're having waves. But if you look at that fourth wave, that's the Omicron wave, we didn't see a spike in deaths. It hasn't been exactly the same in all the other provinces, but Gauteng is the best example of where most of the people are either have immunity from prior infection or are vaccinated. And the net effect in a densely populated province like Gauteng is that you can have cases, but the deaths stay down. And this is now the picture that's emerging in most parts of the world. And that's really the data set that's behind the loosening up of the economy, the restrictions, the speech of the president last night. And I'll show you the study that's actually there. Or before I go there, if you take a look, I couldn't resist keeping the slide in. If you take a look in or around the beginning of February, there was a little uptick at the end. And, you know, we all kind of got quite concerned about this because we thought it might be a new variant. And in fact, it was a new subvariant. That's the BA.2 subvariant. But because of the large amount of background immunity that we have in this country, actually the net effect was that it was just a little blip. So BA.2 has taken over the whole of South Africa now. Almost 100% of infections in South Africa for COVID are with the stealth variant, or BA.2 as we call it. But the spikes we're seeing in Europe, the US, in a place like New Zealand, Hong Kong, are all this new variant. And I wish I'd added one more slide, which is a comparison between what's going on in Hong Kong and New Zealand with this BA.2 variant. In Hong Kong, there's a lot of mistrust of the Chinese government by the population. And so the vaccination coverage levels are even lower than South Africa, in the region of 35 to 40%. And Omicron has caused a lot of death there. There are more deaths from Omicron than any previous wave, whereas New Zealand had 95% vaccination coverage, and they've had this kind of picture with very little deaths. So it constantly reminds us that, as the President said last night, vaccination is the quintessential public health measure, and we need to get it much higher up there. If we had 80 or 90% vaccination coverage, you know, we wouldn't see this. Don't want to waste time now. We wouldn't see that fourth wave of deaths, which is in the region of about 30,000 deaths for the fourth wave. I'm coming to a close now. So just to repeat that, in the COVID wards, we need to figure out a way now to normalize how to manage COVID patients, and whether that's in a side room in a normal ward, or to continue with COVID wards, or to create a new category of wards for incidental COVID. Those are complicated discussions that we have to figure out. And the second point about these tents, you know, we have almost no COVID now in Tshwane, but all our patients still have to wait for 12 to 24 hours for a COVID test. If you're in heart failure, you don't want to be in a tent. You know, you want to be in an ICU, and so we really are at this difficult stage in the health services where we have to figure out sort of our exit strategy here. And what's driving that exit strategy gives us confidence is this sort of graph where the deaths are down, even though we might have a fifth wave or a sixth wave. So this is probably the most important study of all, done by Professor Shabir Mahdi, you know, well in advance of all of this thinking. He set up the study months ago, and it basically shows he went from house to house and sampled everyone from the age of 5 upwards, and he showed that in South Africa we already have this high level of background immunity. He doesn't differentiate in this study between prior infection giving immunity or vaccinations, but you know, this is what every country in the world should be doing, and they're not doing it. Public health decisions must be based on these kinds of data. So I'll end on that point saying we're at this interregnum now where we have to find a way back to normality. It's a little more complicated within the health sector than it might be in the economy. And then I just want to thank a few people who I talked to, particularly David de Villiers and Nicola for those slides. And I hope I stayed within my time. Thank you very much, Leanne.
Awesome. Dr. Abdullah, thank you very, very much for that very insightful presentation, and just looking into some of the data and the graphs and all of that stuff. I've never been one for graphs, I really haven't. But suddenly, when COVID came, all I could look for were graphs. I mean, it's just insane how our minds changed. And these kind of things are so interesting to see exactly how it affected the healthcare system, those excess deaths, and that immunity, that herd immunity that, South Africans, whether we're talking about the fact that that's vaccination or the fact that we've had COVID, we don't even know about it, is something that is very, very interesting. Now, remember, any question that you have got, post it into the chat, and I promise you, we'll get as many of these questions through, because we're going to have an opportunity to speak to Dr. Fareed when he joins us in a short while.